Excellent. So today I'm presenting on the Health Project. It's an acronym for Healing and Empowering Alaskan Lives Towards Healthy Hearts. This is a collaboration with ANTHC, with UC San Francisco, with the Norton Sound Health Corporation, and with Stanford University. The grant is funded by the National Heart, Lung, and Blood Institute, and I've got our clinical trials number there. Today I'll be focusing in on one of the outcomes, and it is looking at the tobacco cessation outcomes. Our trial is a telemedicine delivered tobacco cessation treatment conducted in rural Alaska Native communities, and this was a randomized controlled trial. And I'm Dr. Judith Prochaska. I'm at Stanford University, and I want to acknowledge that this is very much a team effort, and I've got my colleagues listed there. And to show you where we're kind of all spread out and about. So a number of us down at Stanford, Norton Sound Health Corporation, at the Alaska Native Medical Center, at the University of Alaska Anchorage. We had two doctoral students, Maria Crouch, who's now at Yale, just finishing up her internship after she completed her PhD, and Jordan Scan, who's now in, I believe, the Department of Epi at ANTHC, also completed his doctorate. Both Maria and Jordan had diversity supplement awards on the as part of this R01 grant that we had. And then a number of us here. We'll continue. So our trial, we aim to recruit 300 individuals who identified as Alaska Native adults, men and women who smoked cigarettes daily. It's a two-group randomized controlled trial, and the design was to have two active interventions. We wanted to randomize at the level of an individual rather than as at a community. And we wanted everybody to feel that they were getting something out of participating in this research project. So we wanted active interventions in both conditions. Group 1 was focused on tobacco cessation and promoting physical activity. Group 2 was on native diet and promoting medication adherence for controlling hypertension or high cholesterol. And our aim was to test the efficacy of multiple risk behavior change interventions for cardiovascular disease prevention. As I mentioned, it's telemedicine. We were reaching out to individuals in their communities. We were based at Stanford as well as ANTHC, and we used Fidwire for the technology to do this counseling remotely. We also had program materials that were provided, manuals for each group, pedometers in the tobacco cessation group, nicotine replacement therapy in the tobacco cessation group, a really wonderful traditional food guide in the nutrition group. As I mentioned, we were based in the Norton Sound region. Our largest community was Nome, and we went and recruited from every community in Norton Sound except for a Little Diomede, which we had some challenges getting to in terms of flying there. Our recruitment efforts, we worked with the Nome Nugget. We had an ad in there. We had some stories, some reports in there, some articles. We were on the radio, both in Nome as well as it's in some of the villages. And we did a lot of tabling, so being present in the community at the grocery stores, at the Norton Sound Health Corporation, at different dance events or sporting events to be present to recruit individuals. We recruited participants between June 2015 and December 2018. We made over 100 recruitment trips, and Mariah Knox was one of the main leads on that effort in terms of recruitment, and she published a first author paper on our efforts there that were successful. We made over 200,000 air miles that were traveled, over 500 days in the field. We screened, we consented just over 300, and we randomized 299 people into the study. Some pictures from our travels and our outreach. And that's Mariah there. So in terms of our participants, as I mentioned, everybody identified as Alaska Native. Everybody was over the age of 19 because we're focused on tobacco use. And they had to either have high cholesterol or high blood pressure. They had to smoke at least 5 or more cigarettes per day because we were offering nicotine replacement therapy. And our participants, it was nearly balanced, 50-50 in terms of male-female, 61% Nupiaq, 31% Yupik, 8% another or multiple tribal groups. And their average age was 46 years. These are our baseline smoking characteristics. The sample averaged just over half a pack per day. About 2/3 smoked within 30 minutes of waking, which is a measure of dependence to nicotine. Few were prepared to quit in the next 30 days, so 19%. With our study, participants did not have to want to quit smoking to participate in the study, and we tailored our interventions to their readiness to quit. 10% reported using additional tobacco products, 9% chew or snuff, very few were using e-cigarettes, and very few were using IGMIC. 14% reported no smoking in the home, so very few reported having a smoking ban in the home. Our outcome measures were 24-hour quit attempts, reducing cigarettes per day from baseline, self-reported 7-day point prevalence abstinence, so not using any cigarettes or any tobacco products in the last 7 days. And then we also did a biochemical verification by testing urine for anabasine. I should mention with the intervention, we had counseling that was provided through telemedicine. This was done at baseline 3, 6, and 12 months. The counseling was guided with a computer intervention. And so people were asked about their readiness to quit smoking or to address the other risk behaviors, their beliefs and their ability to quit smoking, the pros and cons of quitting smoking, and their engagement in different strategies for quitting smoking. The counseling program would then print out a report that was mailed to their home. That computer system would remember their responses from earlier sessions and would tell them how they had changed over time. And it was person-to-person delivered. So it was counseling that was done through the computer, through the telemedicine, and then guided by this system that was systematic but allowed for flexibility to tailor to the individual. At any point, if the individual wanted nicotine replacement therapy, they were facilitated in getting access to that. They also got a treatment manual delivered to their home that had counseling strategies to help them move through the stages of quitting smoking. So in terms of acceptability of the intervention, it was high. So we measured that on a 10-point scale, and it was high in both groups. So participants tended to like the interventions. They rated it over 8 on a 10-point scale. And the degree to which participants liked the intervention was high regardless of gender, regardless of age, regardless of living in Nome versus an outlying village, regardless of which contact it was, the baseline 3, 6, or 12, so it stayed high over time. Our study retention, we had data on 80% at 18-month follow-up, so we're really pleased with that. And again, shows some of the manuals there in that photo. Here are our outcomes. So our tobacco outcomes at 18 months, most participants made a quit attempt that lasted at least 24 hours during the trial, during the 18 months that we were doing assessments with them. It was 70% in group 1, which was the tobacco cessation arm, versus 64% in the comparison arm. And that was not significantly different by treatment arm. 1 in 3 participants greatly reduced their smoking. And we considered that by a reduction of 50% or more from baseline. And again, this was not significantly different by treatment arm. Older age predicted greater smoking reduction, but not the treatment group. Participants in group 1 were more likely to use nicotine replacement therapy during the trial compared to group 2, so 54% in group 1 compared to 28% in group 2. And then in terms of quit rates, less than 10% were quit at 18 months from all tobacco products. Being quit at 18 months was predicted not by treatment group, but by their readiness to quit at baseline. So those who were in preparation saying, I'm intending to quit, I've made a quit attempt in the last year, they were more likely to be quit at 18 months follow-up. Only 1 participant per group was bioconfirmed as abstinent. So to summarize, our telemedicine delivered prevention counseling was feasible. We were able to deliver this from our offsite area into people's community clinics, and it was deemed to be acceptable among Alaska Native men and women in the Norton Sound Bay area. Participants receiving tobacco cessation counseling were more likely to use nicotine replacement therapy during the trial. Most participants made a tobacco quit attempt, and 1/3 greatly reduced their smoking. However, few reported being tobacco-free, and quitting smoking did not differ by treatment group. I want to acknowledge the Norton Sound Research Ethics Review Board, which has guided us throughout the course of this study, the Norton Sound Health Corporation, and especially Rivaline, Cameron Piscoya, Dr. Stephen Daniel, and Angie Bourne. Our Data Safety Monitoring Board members, Drs. Tina Woods, Teresa LaFramboise, and Andrew Pipe. And then to acknowledge that ProChange Behavior Systems developed the computer-based intervention and the manuals. Our team adapted the manuals for the community participants. And as I mentioned, VidYO provided the telemedicine platform for intervention delivery. Thank you. Okay, let me come back to you and happy to take any questions.